Rajiv is there.
Prasad
is there. You guys can
Start
actually
he
keep
may
on
join
asking
later.
questions.
Yes, now I think we are going live.
We are live, sir.
Perfect. Good evening, friends. Welcome to the basic arthroscopy course today. After a successful course of knee arthroscopy, we come to shoulder arthroscopy, and from today, in coming weeks, we will cover almost all the topics of basic arthroscopy. We are going to talk about shoulder arthroscopy portals, the positioning of the patient, equipments, something very, very basic stuff about people who want to mature themselves from knee arthroscopy to shoulder arthroscopy. We have Dr. Samanta, who is Secretary of the Indian Arthroscopy Society, a very senior arthroscopy surgeon who has got immense practice, and his training has actually also evolved the way everybody's training has evolved from a knee arthroscopy surgeon to the shoulder arthroscopy surgeon. So he has gone through all that nitty-gritties of learning arthroscopy right from the basic. He's one of the best guys to talk about the basics in shoulder arthroscopy regarding positioning, portals, and equipments required. On the panel, we have Dr. Arvind Gupta. Arvind is from Patna. He is a well-respected arthroscopy surgeon doing a lot of arthroscopy work in both knee and shoulder. And we would also be joining with Dr. Sujit Jos, who is going to join shortly. We have on the panel, in addition to both of these, Indian Arthroscopy Society EC members, Dr. Rajiv Raman from Calcutta and Dr. Ranjit Panigri from Odisha. It would be a very, very good informal discussions today. And I would request Samantha to stop in between to entertain any questions, and would request our panelists Arvind, Ranjit and Rajiv to keep on asking some questions so that we stimulate discussions. I think Sujit is also joined, and we are admitting Sujit onto the panel. I think so. If you can ask him to unmute, Sujit can unmute, and Samantha can then start.
Okay.
Yeah, Sujit, welcome.
Good evening. Good evening. Good evening. It is a welcome from the IAS team, and it is a great honor that you people have joined, and you and this senior guy like you and my brother and close friend like Arvind is there, also my junior colleagues, and they are very, very close to me, like Ranjit Panigrahi and Rajiv Raman. One day probably when we are teaching cadaveric session, they have attended our sessions. Now they are my friends and they can teach me something. Okay, because they have gone ahead. Today this is a great honor from my side, because though I am the secretary of the association, but in our association everybody are like colleagues. Okay, and in our team IPS is the captain, I am the vice captain, so everything is going on with IPS is taking care of that, and all the people like Sandeep, Ranjit, Rajiv, Arvind, and all the EC members like Bhupesh, Karthik, Santosh, they are doing the job themselves. So this is a great honor that after Bhasin sir and Maheshwari sir, they have told about the basic things about the knee. And I am, when my captain told me you will be talking on the basic of the shoulder, basically this is a great honor as well as this is a challenge to tell something about the basic shoulder after somebody like Bhasin sir, Maheshwari sir, they have told about the basic knee. So I'm going to start the slideshow. Is it coming, Sandeep?
Yes.
Yes. Okay. So this is my topic is whatever my captain has given me is like your position, portals, and the instruments. So today also I talked to my friend Dr. Sujit how the program will go, and I will take Arvind also that this is not a sort of presentation sort of thing. This is an interaction. This is not a monologue. If you feel that you want to add something on any point, then you can stop me. We can add some points. And basically, this is a discussion sort of thing. Even if some questions are coming in the chat box or in the YouTube or in the Telegram, I think Dr. Sandeep will take those questions and we will go ahead. So basically, I'll be going in 3 categories. Like first, how to position the patient, then the portals, and then the equipments. What are basic needs for a when you want to start the shoulder, because we have all graduated from the knee scopy. We have not jumped to the shoulderscopy as such. So if you have done like 50s or hundreds of knee scopy or the PCL, then we go with the Bankart and the rotator cuff, even it is tougher. So this is a very, very gradual process, and we have struggled hard because when we started doing shoulder, probably 2020 years, like in 99, 2000, we started doing the shoulder all together with IPS and all. So the positioning of the patient is very, very important. It can be lateral or the B chair. We have learned in both the ways. Okay. So Sujit, do you do in all lateral or B chair? What is your position? For the Bankart or a cuff, it is different.
I'm selective, Dr. Samanta. I do Bankarts in lateral and cuffs in B chair.
Okay, so I know some of the people, those who are very confident that when they do the Bankart, they do the lateral, and when do the cuff, because they do the B chair. This has got two advantages. One is that your cuff will be looking more anatomical, and the changing from the scopy to the mini open or the open or whatever, even for the orientation and change over to mini open is easy. Okay,
Yes,
so what's your take, Arvind? How you do it?
Sir, basically I am trained in the lateral position at a sports injury center. So still I am doing in lateral position. Though I have seen Dr. Burkhardt, who is doing in B chair position. Dr. Jody Bear, he is doing in B chair position in most of his cases, almost 99%. But I am still doing in lateral position because of my major training in lateral.
So you do more or less in lateral.
Yeah, lateral decubitus.
Both for the Bankart and cuff.
Yes, sir. For both, any Bankart, cuff, AC.
Whatever shoulder, basic. That's why I am telling that whatever shoulder scopy you are doing in lateral.
Yes, sir.
Okay, Ranjit.
Yeah, I am doing all things in lateral decubitus.
Rajiv. Okay, I think his connection is lost. Probably I also sometimes, because I am trained probably in many of the mentors who are all over the world, who are world famous. When I went to Barkhat also I went to Lafos also, I went to Pascal also. So whatever I have done, both the lateral and B chair, still I will go with all lateral in my position because I have tried both the things. So whenever for the basic purpose, with those who are they want to start, or the beginners of the shoulder, I think the lateral position you can start ahead, and you can do somebody those who are doing it lateral, because the thing is, the most advantageous thing in lateral is that it is very easy to position the patient, and the second thing is that your anesthetic friend is very happy, and third thing is that in B chair you need a special table with a head support. Otherwise, you cannot do it. But the advantage of the B chair is that I told you at the beginning when Sujit added that from the arthroscopy, you can turn over to your mini open or the sometimes to the lateral J. It is very easy. Okay. But the B chair, the anesthetist is not happy because of the hypotension of because sometimes they have because suppose in the cuffs, these are geriatric patient. If there is hypoxia, then there is some brain problem. Okay. So positioning is difficult, but B chair, your anatomical thing is much easy to look around. Agreed, Sujit?
Yes.
Okay.
Basically personal comfort. And it's mainly
basically the personal comfort. Again, another one trick I want to tell, who are just the beginners who have not been seen, whenever you do your lateral position of the B chair, I will request that you every time, even if you're a senior guy, you see that your position is perfect. Because if your positioning is not perfect, you will be struggling to create the portals. So whenever do your lateral portal, remember this picture, that if when suppose the patient is dead lateral, as because your glenoid is not absolutely parallel when it is dead lateral, so you have to, because you know the glenoid is 30 degree oblique, so to make the glenoid parallel to the floor, the whole torso should be towards the back side 30 degree. You see, there is 30 degree here. Only because, so that your glenoid, which should be parallel to the floor, so that you don't have to struggle and will easily go inside.
You can call it a lazy lateral.
Yes, this is the because this is known as the lazy lateral. That means 30 degree. Why 30 degree? Because the glenoid is oblique 30 degree. That's why the glenoid should be parallel to the floor when you start ahead.
Correct.
Okay. So thing is that you have to take care of the head, of the eyes, everything you have to take care. You can, there are so many, the spiders are there, costly things are there, but we have made it very simple, like simple with the traction device, which you put for the fracture neck or trochanter. Even you can, from this device, you can do these things. But if you have the spider or special hand holding apparatus is there, it is good. Sujit, do you use this way, or you use the spider, or even if you do sometimes the lateral traction?
I started this way, Dr. Samanta. I had a pulley, double pulley. Nowadays, I got a spider, so I'm using that now. So
Okay.
it doesn't have any disposables, just the bandage and the equipments tied to the spider.
Dr.
My question is, are you happy with only the lateral traction, or this way traction, or you give the 90-degree sort of traction, true traction?
This traction this way.
This way, okay.
Yeah. I started with pulley. Yeah, exactly same.
Yeah, sometimes you can make from the, if you take this picture from the screen, you can go to your some local vendor, those who are making the saline stand. Even you can make this sort of pulley where you can do your traction device, or else sometimes you can even with the two traction device, one in the 90-degree plane, so that the arm can be abducted and you can create the joint space. Okay. So this is the way, but I am not doing in that way. I am doing the simple device, like simple traction. How much traction some people tell. It is just to hold the arm. It is not the traction is going to distract the arm. So I think probably even if you do 5 pound or the 7.5 pound, according to the arm weight of the hefty patient, you don't have to put much of traction just for the sake of distracting the joint. It is just holding the arm. Understood? Then the question is, how much should be flexion and the abduction? Always remember, the abduction is around 30 degree and flexion is around 15 to 20 degree. Sujit, anything to add on?
Yeah, perfect. And lateral bolster will come after the draping is done.
Yes. So another thing is that what Dr. Sujit is advising, that if you are putting no traction like 90 degree this plane, then we are not giving the two traction like a V7. So if you just put a bolster or the roll sheet just below the axilla and the arm, automatically your joint space will be increased. And if you put the bolster here and somebody holds the elbow here, then that is a great to get your joint space there.
Yes.
Okay. So this is the way you have there. And always remember, when you put the lateral position of the patient, please remember just put this cotton around the common peroneal nerve. Because if your surgery is more than suppose 2-3 hours for the calf or whatever, when you are a beginner, your common peroneal nerve is not should be just touching on your hard surface. Understood? Because how you do your position like your bipolars or the total hips, so your common peroneal nerve, even this other arm, there should be one sort of the common trick is that you can give a 500 mils of saline just at the axilla. If you put this 500 plastic bottle of a saline axilla, your your axilla will be decompressed. Understood? How you take care of the other arm, Sujit?
The other arm is usually kept forwards flexed under the head. The anesthetist will take care of that. Again, padding the elbow as well as the wrist so that there is no compression.
Arvind, anything to add on?
Yeah, it's 90-degree flexion of that opposite arm. And only thing is that we don't have to go that side. So no need to worry about that much of the opposite arm. And one thing about the abduction of the operated arm, that should vary according to what surgery you are going to do. About in rotator cuff, you should be on toward lower side and no need for bump in the axilla. And for other surgery, you need to be slight higher side of abduction, maybe 45 or 60 degree with bump in the axilla.
Yes, that is there because that I'll be coming. So when you do what I think Arvind is referring, that when you do the bank cut, if I go back to the other picture, I think when you do the bank cut, you put the bump over here because you need a space in the inside intra-articular space. But if you distract with the bump when you do the cuff surgery, you will have reduced space in the subacromial region. So in the rotator cuff, even if you don't do the 30-degree abduction, if you just keep it in 15 degree, even you lessen the abduction of your arm, suppose I am meaning this arc. If you lessen that arc, you will be having better space in the subacromial region. Understood? So you have to protect the patient from head to foot. That means head to foot, why I told? Because remember, you have to protect the eyes, because all the fluid and everything saline will be dripping on the face. So it has to be watertight, and there should be gauge in the, there is protection in the eyes, on the eyes. Okay. Then the axilla of the other side I'm referring to, and the other arm, because he will be sleeping on that side for more than like 2 hours. So there might be pressure. And remember, the arm should not be abducted like more than 90 degrees, because sometimes there might be brachial problem even. Understood? So it has to be, the surgeon has to be very meticulous in positioning, not because of your security of the patient, but for the protection of so many things. Remember, from head to foot. So this is the picture from the textbooks, how the things should be positioned, because in knee it is not very problem, because problem is that when your Boyle's apparatus or the anesthesia machine is on the head side, because if you have a short tube, then the movement of the surgeon or the assistant, because suppose you are the surgeon at B position, your assistant is on this side, sometimes you have to move around to that side, sometimes during the surgery, then it might be problem if the anesthesia guy and the tube is very short. So for the calf or the bankard, you can have the extension of this tube which goes to the foot side. So your whole Boyle's apparatus come to the foot side. So your head side is completely free. Do you do that, Sujit, in your place?
Yes, of course, of course. The foot is padded well, and
yes. So
exactly like this.
So I think this is a great point for the juniors, because you can just, it is a not very costly thing. Only thing is that you have to have one extension of your tube, so that the whole, your Boyle's apparatus goes to the foot side. So you can, so that the surgeon which is at B, he can move around this way.
Yes.
So this is very, and the sterility on the head side, it can be completely covered, and sterility is excellent. So this is a great point which I learned many years after. So that's why I'm giving you the trick. So you can see from this picture. So this is a picture of 2005. Okay, 2005. So this is the way we started in 2000. This is me, and this is another two of my colleagues, and that time they were my PG students and fellows. Now they are co-consulted me in the same hospital, Dr. Nikhilesh and Dr. Mohorshi Nondi. They are the consultant in the same hospital. So this way we started. So I do all in lateral. So this is the primary posterior portal. Okay. And each year I have already told you that you have to have the special table for that. You have to be very cautious how the patient is oriented, and also the head has to be taken care of, and your whole posterior side has to be free. Because if you do in a common table where you cannot detach this part of the table, this side, then your space is very limited. Agreed, Dr. Sujit?
I disagree a bit. I was with Dr. Ashish when I started my shoulder work. So what he does is, that's what I do now. It's a normal table, but the head is strapped to the corner so that the shoulder lies outside. So it is a normal table, and it is strapped around. So it's quite comfortable. I shifted from the head ring, but the head ring comes in the way sometimes.
So okay, so you are using the normal table. So because problem is that if you have this table, these tables are a bit costly. Yeah. Because it is problem is that these tables are only with probably the MACE system, or some people are doing even the copy of the MACE. So that your thing is that if you can detach this part of the shoulder, your whole thing on the backside is very comfortable. Otherwise, if you do in the common normal table, then the whole body, all the whole torso should be on the edge of the table, so that your shoulder is out of the margin of the table. So I think Dr. Sujit is referring to that only. Yeah. And remember that for the B chair, you don't take like 70-degree sort of angulation of the upper body. You just do like 45-degree, between 60-degree, it is more than enough. Because if you do 70-degree and call the anesthetist, probably on that day the anesthetist will not come, he will take leave. If you call him for a more than 60 years guy, if he's hypertensive and diabetic, there is a problem. So I think you don't need that much of forward elevation or whatever the position of the 70. Arvind, have you ever done in B chair?
No, sir, I have not done in beach chair, but I have seen many surgery in beach chair by Dr. Burkhardt and Jody Beer, and they use a such type of table. You need to, the head support is there, and the complete back is free. Whole
Yes,
back is completely free.
Because I am lucky that I am in a corporate hospital where everything is available. You know that, Arvind. So
Yes,
I am having that this modern Mackey table so that I can have the position in beach chair. But sometimes I do beach chair because if some of my fellows are telling me, but I will always love to do all my cuffs. And nowadays, if you tell me to do someday, I will be doing all in lateral because I am not fatigued. Another point I forgot to tell in beach chair is that when you do your posterior portal is this way, your water will always flow back to your junction of the camera and the lens. So might be there is fogging because if you use the lens cover and if the water seeps off every time because there is the gravity, because of the gravity, your water will seep this way. So there will be always a fogging, and also there is a water leakage and the break of the sterility if you remove that plastic. So this is a point against the beach chair. So I don't do the beach chair because I think beach chair is clumsy for me. And main problem for the beach chair is that my anesthetists are not happy.
I'd like to add there, what I do is I tilt the table to the opposite side by 20 degrees so that the water does not flow onto the camera. It is a big problem, as Dr. Samanta said.
Yes, that is also point. But problem is that if when you do the cuff, you can elevate your lens like this way. But when you do the bank cut, problem is your more or less it is horizontal or it is towards the floor. So that is the problem when you if for the cuff, because already your portal is cuff for the much superior, 1 centimeter superior than your classic bank cut portal. So I have discussed about the advantages and disadvantages of both the lateral and beach chair. I don't force that you have to do in lateral. If you are trained in beach chair, both are good. But thing is that whatever way you are trained or your mentor is doing, or you do yourself during your cadaveric training, you follow that. It's not that the beach chair is superior or I am not forcing the lateral is superior than beach chair. Whatever way you are comfortable, that is the main trick. I am not forcing that lateral is much better than the beach chair. Agreed, Dr. Sujit?
Yes, of course.
Dr. Arvind, anything to add? Ranjit?
Yes, sir, rightly said. I think one of the biggest advantage of beach chair is whenever you need to do open or mini open after arthroscopy, you don't need to change the position, and you can do in beach chair a mini open and open at the same time. But in lateral decubitous, you need to do draping and pending again after this finishing of arthroscopy job.
Yes. Ranjit, any point to add on if I have forgot anything with the beach chair and the lateral?
Sir, it's basically as per the surgeon's comfort, as everybody agreed. And some surgeons, they prefer the beach chair position only for cuff surgery. And the rest of the surgeries they do in the lateral position. But again, it's the zone of comfort where you are. So both the positions are good, I think. And as Arvind had mentioned, Burkhardt is also doing most of his surgeries in lateral position, especially in instability surgeries and the postural labral surgeries. What I have seen, he is doing in lateral position. So both the positions I think are good, and it's a matter of comfort that you decide which position you want to do.
Another part, don't take me otherwise, because I have already been trained with even with the beach chair. The problem is that when I do in beach chair, my hand should go like this. So if your surgery is more than like 2 hours or something, you might be fatigued because of your high position of your elbow and the arm. But I'm not telling against beach chair. But this is a problem. But I think Sujit is smiling so that he is not agreeing, because he is probably doing in mix and match like both in lateral and beach chair. This is another one negative point, because your hand has to come from a up to down direction. Yeah. So you might be fatigued after 2 hours. So these are the points both in plus and minus. Sujit, want to add anything?
Yeah. Dr. Sujit, how comfortable you are in doing the posterolateral surgeries and instability surgeries in the beach chair position?
I don't do instabilities in beach chair, Dr. Ranjit. I do only cuffs in beach chair. Only arthrolatars when I'm doing. There is one place where I come to beach chair position for instabilities. Otherwise, I do all the instabilities in lateral position. only cuffs I go B chair, and there we are working on top of the shoulder, so the angle is always upward only. So our hand is like this. We don't have to go up. So if you are trying to do instabilities in rotator cuff in B chair position, that is very difficult because you have to go into the intercircular shoulder.
Only probably for one issue, I will be agreed with Dr. Sujit that if I am going to do the arthrolatergy, so I'm not going to that extent because this is probably another one big topic. Probably in arthrolatergy, you go with the B chair. Why? Because in two reasons. One is that in arthrolatergy, the viewing and the anatomical orientation is much better. Second thing is that I assure you, in one go, even if you have seen 50 surgeries, you have done 50 cadavers. For the first day, you won't be able to complete the arthrolatergy in one go because this is a sequential thing. You have to do sequential, if some part arthroscopic, then open and reduce the open part, and then we go ahead with the arthroscopic latergy. So this is the way, because even if you Gary Gartzman book, then he has told like arthrolatergy is a sequential learning procedure. So the only probably in one thing I will go with the big chair is the arthroscopic latergy. Agreed?
Yes.
Yes,
Okay. So I think we have discussed everything about the positions. Can I move ahead, Sujit?
Sir, in B chair position, so what should be the position of the arm, and the traction is required or not? We have not discussed till now, sir. Dr. Sujit can throw some light.
Yes, Dr. Sujit, are you using something for the holding of the arm, your spider or whatever?
Yes, I do the spider. Initially, I used to have the spider man and woman. The interns used to do that, but it's very difficult holding the hand up, as you said. So you need to have a dedicated hand holder, the Tremano or spider, which I have now, which is very comfortable to use. And I don't use the disposables. I just strap it onto the metal bar and it's kept there. So that's very comfortable. You can even give the traction, and it's got the traction adjustment where you can pull the hand as much as you want, and it stays where you want it to.
Yes, if you use the whatever he is telling, like the Spider-Man, that means your assistant, who is completely dedicated for the arm purpose. That is the Spider-Man. Yeah. Or else you have to have the spider, where the man is not there, is the machine.
Yeah.
Sujit, let me know. Do you give brachial blocks also? Intrascreening blocks with the GA for your patients? Do your anesthetists do in BCA?
Nowadays, I am doing intrascreening block for all my shoulder surgeries. All.
Because we were doing a literature review. In a beach chair position, if there is a block which is there, plus the general anesthesia, there are some incidents of bradycardia and hypotension episodes.
Yes,
this might be fatal for patients with underlying cardiac conditions.
Yes, that is
whenever we do beach chairs, we try and look into the cardiac condition and then only give a combination of a block plus general anesthesia. But it is quite safe to give a block with GA in a lateral position.
The thing is that the most advantageous why we give the brachial block. There are two things. One is everybody will answer like the post-operative analgesia. It is not like that. If you give the brachial block, the anesthetic people are very happy to maintain the hypotensive anesthesia. So that is the advantage of your giving the brachial block. But what Dr. IPS Oberoi has told, that you have your cardiac condition and has to be checked when we are doing for a beach chair, and that too for a longer period, and if you need hypotensive, because these guys are already been geriatric. I have already mentioned the cerebral hypoxia is extremely dangerous. So the anesthesia, I have probably told 5-6 times, the anesthesists are not very happy with the beach chair. And this problem with the hypoxia along with the bradycardia is the real problem with the geriatric group. I completely agree with that, IPS.
Yeah, because whenever there is hypotension, there is usually a reflex tachycardia. But with the but in these conditions, they usually have a reflex bradycardia. So it's a BH episode, bradycardia hypotension episode. Both are actually not good for the body. So you lose the blood pressure and you lose the heart rate, and then suddenly something might happen.
Yes, that is a problem.
Skeptical about blocks with general anesthesia in a cardiac patient in a beach chair position.
No, we have to be very cautious with the cardiac patients.
Samanta sir, can I just start one point?
Yes, Dr. Bhupesh has joined. Welcome, Bhupesh.
Sir, I'm there for a long time. With respect to shoulder position, like we can't do arthrolatergy in beach chair. One condition where everybody prefers lateral is posterior labral repair.
Yeah.
No, that we have already discussed. That is already discussed. Yeah. And also I have discussed about the arthrolatergy, why the beach chair is more advantageous rather than your this thing. We have already discussed, and I will come to the point again when it come to the portals. So once we are happy with, yes.
one with sir, anybody using this vacuum bean bag in the lateral
vacuum big bag, it is very easy, it is very cheap, and your lateral position, it is very, I have seen with Burkhardt, every case he is using this, but it is even with your posterior support, how he position with your during your total lips or the bipolars, it is easy with that. It is not, I am not using the vacuum thing for my positioning, but it is very good. But it is very good. It is very good.
Especially in emaciated patients where you might have pressure sores in a long, but if you pad them well, especially in the trochanteric area, the lateral popliteal nerve area, also in the ulnar part where ulnar nerve is there, the medial epicondyle when the arm is extended, they are good enough. With the bean bag, probably the issue of padding is already taken care, and so I think chances of
I think
during
the positioning we have told about the IPS probably that how to take care of the other axillary thing, other side, then the trochanteric area, and also I have mentioned about the lateral popliteal. So these things should be every time the surgeon has to check it, or else is the first assistant or the who is the fellow. It should not be missed even. So once we are happy with the patient positioning,
yes, Arvind wants to ask Sujit, you raised your hand.
Can I add something more?
Yes, always, Sujit.
While positioning, it is very important, especially when you start in beach chair, to have the anesthetist know, or if it is a younger anesthetist, be careful that the leg is tilted up. The Trendelenburg tilt is very important on the table. Let's not lift the head up. Go slowly. Tilt the head up 20 degrees. Again, tilt the table down. Again, tilt the head up. Go slowly. The newer generation beds do that automatically. Or you can
yes, another one advantage I think Dr. Sujit is referring, because if you don't do that, probably during the surgery, patient may slide down. So
that is also there.
So the pillow should be, the knee should be flexed, hip should be flexed, and the one pillow should be just below the knee, and there should be slight sort of angulation at the hip joint so that the patient doesn't slide once you fix the patient. So these are the very, very important points in beach chair position. Am I correct, Dr. Sujit?
Yeah, that help in correcting the hypertension problem as well.
Yes.
Hypertension could be related to the.
Do anybody of you, especially in winters, I mean, in North we have a lot of winters. We often use air warmers in patients with shoulder arthroscopy. So do you guys do it?
Yes. That is very good point. Yes. It is a must, because sometimes if there is a leakage for many things, sometimes it is hypothermia. Is also been reported. If you are doing surgery is 2-3 hours and whole fluid is not, it is not the airtight draping, then the fluid, the patient is totally been flooded with the water and there is hypothermic episodes even. So you have to go use these warmers.
Especially in orthopedics, we keep our operation theaters at 16 degrees of it's already quite cold. And
no. I think in all modern OTs they are having the electronic this thing. The warmers are all been there with the plastic bag sort of thing.
Yeah. Sandeep has a question, I think. Sandeep.
Yes. No, sir. It's just a comment actually regarding beach chair position. Like what I have observed in United States, that they make compulsorily put goggles to the patient whenever they are putting in a beach chair.
Okay. So anybody of us using goggles and earplugs?
I am telling you, this is a very, very important point, because why I told about the goggles, the eye protection, because
instruments.
Because instruments, and more true. Just listen to me very carefully when we are going for the cuff repair, because problem is that when you repair the subscap, remember this is a very, very important point. When you repair the subscap and your anchors, the angle is for 25 degree is going to the subscap thing, and all the sharp instruments and the anchors will very close to your eyes. So whenever you tend to do your subscap or the cuff repair, it is better to whatever goggles we use for the kit purpose, safety kit sort of goggles, that you can put on the even with your iPad and the goggles, so that your sharp instruments will never hit the eye.
Also in lateral position, you should put some ear plug as well. Sometimes
Yeah,
water
yes,
would go into the ears
uh,
as well.
yeah, ear plug should be there, and most important thing is it should be airtight draping. It is if you do yourself, it can do it. You can do the normal drape, and I have seen one thing by Steve J. Snyder how he does. He has done all these airtight drapes. Then he cuts the four your IO drape or IO band sort of thing in 4 pieces longitudinally. After the draping, he attaches and 4 corners like a square. So that automatic second time it becomes another one air and water tight. So this is very easy and cheap.
It's like a seal.
So
Like
now
it's very
3M has come with a shoulder airtight polythene drape. Now last 3 years, instead of IOBAN, I'm using the 3M sticker around.
Yeah.
It's completely waterproof.
Yes.
Yes, it is very good.
Yes.
3M one is very good. So can I move ahead, IPS?
Yeah, sure, please.
So this was the position. Okay. So once you have done the position, then your primary portal placement is very, very important, because the primary portal is the posterior portal. Okay. So if you are not very correct with your primary posterior portal, and if you struggle with your posterior portal, your whole surgery will be in struggle. Sujit, any trick on how you create how you give your trick for the juniors how to create the posterior portal?
Yeah, I create the posterior portal differently for rotator cuff as well as Bankart surgery. For Bankart, I go directly in as textbooks describe 3 centimeters posterior and medial to the posterior middle corner of the acromion. That is where I make my posterior portal directed towards and go towards the coracoid. In rotator cuff surgeries, I go just it's called the Elman portal, where we go just 3 centimeters posterior to the posterior lateral corner of the acromion rather than going medially.
Okay. Arvind, any point, any trick for us and juniors?
Yeah, for initial days, I used to take IV cannula and I put it around 40-50 ml of normal saline through that into the joint. And when I am sure that my fluid is inside the joint, then I used to, this help in 2 ways. One, it's make sure that my needle is in the joint. Second thing also 40-50 ml of joint leads to distension of the shoulder joint. And then I put the knife and then I insert the trocar and cannula. This was my initial practice. And now I am doing directly this 2 centimeter below and 2 centimeter medial to the angle of the acromion for this instability problem. For rotator cuff, I don't go too much medial, but 2 centimeter below the acromion, definitely I choose the place.
Okay. So all agreed that for the juniors and those who are starting shoulder, believe if you had learned how to create the primary posterior portal or the weaving portal for the shoulder, probably you have done 50% of your shoulder arthroscopic surgery. Because primary posterior portal for the Bankart and primary posterior portal for the cuff surgery, both are different. And suppose for a Bankart, it is 2 centimeter down and medial from your acromion angle. And for the cuff, it is 1 centimeter down and medial if you are classic, or else primary you can create the posterolateral portal for the cuff as Dr. Sujit is telling, because he is an experienced guy, very experienced guy. But the starters like those who are absolutely beginners, I will tell them primarily you tie with the 1 centimeter down and medial for the cuff and 2 centimeter down and medial for your Bankarts. Bhupesh, anything to add on this?
Sir, you have told all the points, sir.
Okay. So this is the classic position. This is the picture taken from by one of the Bibles of the shoulder arthroscopy. Always I tell my juniors, you first buy the book by the Stephen J. Snyder. So this is the picture, how this is the position of how your 3 fingers, how it is doing. The thumb is palpating the soft spot. Okay. And the index is palpating the space between the coracoid, the clavicle and the acromion, this angle. And this finger, middle finger, is palpating your coracoid. So this is a 3-finger position, how you palpate the bony points and the landmarks. Then you have to, just like this, acromion, coracoid, clavicle, AC joint, and then you have to draw for the CA ligament. So whenever this is the drawing in the unsterile condition. Suppose how you draw your angle of the acromion, like you have to have the markers like this way. Then you have to draw the acromion. Then this is known as the 50-year mark. 50-year mark means this is the whole lateral border of your acromion. At the 50 or the half of your acromion, you draw a line. So this is the 50-yard mark or the half line of your football match. Why this line is important? Because you create a portal for your cuff surgery here, 2 centimeters from this place. And you remember this, all the subacromial space is in front of this line. So all your subacromial job will be in front of this 50-yard mark. So that's why this mark is so important. Arvind, do you add anything on that?
No, sir. Perfect. You have explained very good.
Okay. So this is the way it was looking from the back side, and this is looking from the front side. So what do you see from the front side? This is the coracoid. Always you mark the coracoid like a big dot. And this is the anterior angle of the acromion. This is the your AC joint, and these are the 2 points, anterior-superior, anterior-inferior portal. So this probably your first year fellow or your senior fellow, they will draw for the practice. Understood? Ranjit, anything to add? You draw your drawings for your all shoulders, or don't do?
Yeah, sir. I do the drawings for all my shoulders. And regarding, sir, posterior portal, I have one query. Because
Yes.
if we go in the standard way, 1 to 2 centimeter distal and medial, that is in the soft spot. So sometimes what happens, it goes through the upper part of the posterior labrum. So sometimes it's very difficult to see some structures. And after doing a longer surgery, because of the swelling, and this portal goes further superiorly and laterally. So if we keep the posterior portal a little bit lower from the starting itself, then it will be easier for us to do a longer surgery as well as seeing all the structures.
Yes, that's why
my
I told.
my view.
That point probably I have already told. For the bank cut, you do 2 centimeters down and medial. If I go back to this picture, for suppose this is the posterior angle.
Yes.
When you do the bank cut, you go 2 centimeters down and medial.
Yes.
But when you do your cuff, your primary portal is 1 centimeter down and medial. Because the cuff is superior structure, you are seeing from the roof. For a bank cut, you are going through the horizontal part. Is a 50-yard mark of your internal glenoid. So your bank cut portal and the cuff portal as two are different. Happy, I think, Ranjit?
Yes, sir. Yes.
So this is the way you draw, and this is the way you give training to your juniors, that drawing, even the experience like surgeon like Ranjit, Dr. Sujit, Dr. Arvind, they are doing all drawings for all their surgery, even they have done in huge numbers. So this is the way it should be looking from the front, from the back, and also from the top. So this is the way how you mark and this is the way how you mark your CL ligament. Understood? So these are the common markings that has to be done for your shoulder arthroscopic surgery.
Dr.
Always remember. Yes, sir.
Sorry to interrupt. Do you make the markings before the draping or afterwards? Because this gets
I told you that this is the marking done by the juniors for the training, because these markings all has to be done after the draping, because once you do this before the draping, this will all go when you do your sterile sort of sterile things, because with the alcohol it will, with your sterilium it will go now, so it will never stick, it will never be there.
Sorry for this.
So no. I told that because the unsterile draping, this is just for the teaching purpose. So this is the way, this how you know the infraspinatus teres minor, because this is the soft spot between your infra and the teres. Okay, but this is the way your posterior portal will come from because I told you the posterior portal, intraglenoid portal will come from the 50-yard mark more or less. Okay, but don't go beyond 3 centimeters from the posterior angle of your acromion. Why? Because if you go violate, then we are very close to the triangular and the quadrangular space. I think it is a criminal to hit these spaces. You should not go that down. So this is the primary posterior portal, which is for the bank cut. I told you the bank cut primary portal and the cuff primary portal is a bit different. So this is the way that I told, it is always been told, the biceps tendon is the lighthouse of the shoulder. Whenever you are lost inside the shoulder, you have to come back to the biceps. As we tell during the knee scopy beginning, that whenever you are lost, you have to come in the intercondylar notch area. So that is the primary in the knee, and in the shoulder, the biceps tendon intraarticular, the long head is your lighthouse. Okay. So this is the way you do your anterior superior portal and the anterior inferior portal for your classic Bankert surgery. Sometimes for your 6 o'clock or for putting the anchor in proper angle, sometimes you need 5 o'clock position, which is through the subscap. So Dr. Arvind, do you do that 5 o'clock frequently, or you don't do?
No, sir, I have never done this 5 o'clock position. But
Okay.
one thing about I want to add in this making posterior portal, the feel of loss of resistance. That is very important, particularly for the beginner. Whenever we start making this posterior portal, one hand, there is loss of resistance. That means we are into the joint. We start with some resistance, and as we pierce the capsule, we enter into the joint, there is loss of resistance. That much of feel always should be there while making posterior portal.
Excellent point from Arvind, because I think this feel, the feel cannot be taught by this thing. It is a very, very soft feel, and always I tell my fellows and juniors that you should never force the arthroscope trocar and sheath, because sometimes the head is softer than your capsule. So if you just force it, you will be hitting the head much, because the space inside the joint is very minimum. And the another one trick, and I think what I have learned over the years, that when you put your trocar, you try to aim towards your coracoid. So if you aim towards your coracoid, probably most of the time you will be going in correct position. Am I true, Dr. Sujit?
Yes, of course. The coracoid gives you the guidance. So always mark the coracoid.
So why I am referring to Dr. Sujit and Dr. Ranjit and all this, because you are the you are the umpires today for me. So this is the
sir,
way.
Sometimes when you are not able to get that feeling, so can we do the marching over the glenoid or from the humeral head, and in between you get that feeling, and then you move your trocar inside. When you get a soft feeling between two bony hard points, and then you move your trocar forward, because many a times what happens initially in our practice, so we were just forcing the trocar wherever we were getting the soft point. Every soft point is not the joint. So that soft point has to be between your glenoid and the humeral head. So what is your take on this point, sir?
Yes, Ranjit, the problem is that I am with the scapular model. You see, this is a scapular model. This is from the backside. This is the backside. Okay. Problem is that you are telling that you have to feel this. You will be, your trocar will be on the backside. Then you move laterally so that you are suddenly you lose the bone. Then you go ahead towards the coracoid.
Yes.
This is a trick.
Yes,
this is a trick that you feel the glenoid. Then you from the medial side you come to the lateral side. Then you just suddenly go inside. But this is a very, very small space, and I think this feeling, what Dr. Arvind and Dr. Ranjit, they are telling, this feel you have to acquire during your cadaveric or the human specimen lab. And the basic teaching is that if you are just aiming towards the coracoid, and if you are feeling that soft spot, if you are forcing your trocar, you are definitely hitting the bone. It is not like that. It is a very minimal force needed. So if you have to force through your trocar, you are not at right point. And there is a sudden loss of resistance. Suddenly you go inside, then only you feel that you are inside the joint. And always the another one trick I am telling, suppose you have suddenly lost your resistance, and if you move your trocar in a up and down motion, if it's moving properly, then only you are 100% sure that even without without the water or the air, you know that you are inside the joint. Not side by side. If you move up and down and it is moving very freely, like this way, up and down, like this way, then you know that you are in the joint. So these are the few tricks, because I always, when I go to the cadaver lab, I told them, if you, for the basic lab, I tell them, if you learn to how to do the posterior portal, you're coming for this primary basic arthroscopic training is over. So this is the way how you go inside. Sometimes you may find blood. So you have to clear with some two or three times, so that once you go inside, you will be, and the basic thing is that when you see this white part, even you can rotate the arm, you will see that this is the humeral head. And when your lateral position is there, your glenoid will be towards your downside. So you have to orient in your brain that my glenoid, whatever white structure I am seeing, it is on the downside is the glenoid. And this round structure, which is from the 6 o'clock coming to the arrow, this is the humeral head.
Sir, regarding portals.
Yes.
Sorry to interrupt you.
No. This is you people will guide me. Then only I will go that way.
Sir, question is to everyone, sir, all the faculties and everyone who is on the Zoom. How many of you inject saline or air before taking? How many of you insufflate the joint before taking the portals and dry arthroscopy?
No. Before arthroscopy or after putting the scope inside?
Well, before taking portal, many people I have seen they do inject normal saline 50 cc or so. Or
no, I think Dr. Arvind has already told, when he started doing the bank cut or the shoulder arthroscopy, he used to give that. But once we acquire that skill of knowing that how to go in a single shot, because that is the feel you have to learn. For the beginners, I will tell you, even if you take an 18G cannula needle and go and fluid goes in and comes out, that will give you the direction. That means because needle is a thinner one, it will go inside very easily. So that needle will give you the guidance how your trocar should go in. And also if the fluid is coming back, that means you are intra-articular. And also if you give some fluid, the joint will there will be more space inside the joint. So when you go inside with your trocar, it will be easy for the beginners. But when you become experienced like Sandeep, then you don't have to do. Another one point is that Sandeep was asking whether to go ahead with the air arthroscopy.
Dry
arthroscopy. This is very, very good. I usually, for all my shoulders, once I am 100% sure that I'm inside the joint, I usually give 20-30 cc of air inside, because in dry arthroscopy, everything is crystal clear. And I know even with the dry arthroscopy, if it is not blood around, I can see everything within 1 minute time. I can do the 2 minutes time. I can do the diagnostic. Then only I take out, start doing the fluid. Sujit, you do that or don't do that?
I started with pre-insufflation, as Dr. Sandeep said. That is a very good thing to start with. When you have fluid inside, you have less chance of scuffing onto the cartilage, on the glenoid and the humeral head. And nowadays, I don't do the pre-insufflation. I do a distraction. I do a lateral distraction of the humeral head myself with one hand and go into the joint with the other hand. So
yes,
that's
because
quite comfortable for me.
Yes. So
I don't do the dry scopy. I don't do the dry scopy.
So it is for the beginners. I will tell you can do with the big spinal needle. Go inside the joint, see that your fluid is coming back. Then this will give you two things. One, the joint will be bigger space, and also you know the orientation from the needle. That because with the trocar you can injure many things inside, but with the needle you cannot injure. So if the needle will give you the guidance and also the space inside. Understood? So once you go inside. So this is the way how you see your humeral head. This is the biceps. I told you that this is your lighthouse. Okay. Then I told you that which is parallel to the floor is your glenoid. You see, this case was for the bank cut I did. So there was a lot of space. There is no labrum over there. Then you can. This is for the diagnostic purpose I'm telling. So once you see that, you can see the biceps tendon and something white. Remember, unless you see something white, you are not in proper place. Correct, Dr. Jos?
Yes.
So if something is looking red, never start fluid. I will tell this another 2 times. If something is looking red at your monitor, never ever start fluid. You are not in proper place. If you are looking white, then you start fluid, you are in good place.
Yeah.
So this is the way.
Yeah.
So this is the way how you go ahead and you see I am doing this switching stick. I can, because this is the top side is, I told you that. Then the probe will come. Probe is your extension of finger, as you know from your knee scopy. So I can see everything inside. You can use the cannula, because shoulder surgery, as because it's a deep joint, not superficial like the knee joint. Cannula is mandatory for bank cut. Cannula is plus minus for your cuffs, but cannula is mandatory for your bank cut, as because you are doing deep surgery, because you have to traverse through the deltoid. But cannula is not mandatory for experienced surgeon. I have seen many surgeons who are cannula-less cuff surgeon. Even I have seen one surgeon who is doing cannula-less bank cut. But I will suggest you do cannula for your all bank cut. You do start with the cannula for your cuffs. Once you are extremely experienced, then you can discard the cannula. So this is the way how you go ahead. And antero superior, antero inferior, I told you, I don't, some people, when I started doing the scopy, I used to do the inside out portal. But the problem in the inside out portal, you are dictated by your switching stick. But if you do with your needle technique, which I showed during my how you position, needle is at your free hand and it will go in proper place. And never ever go to medial side of the coracoid. If you go to the medial side of the coracoid, you are in the suicidal zone, because lateral to the coracoid is the safe side, medial to the coracoid is the suicide. So there are two sides. One is the safe side, another is the suicide. So this is the switching stick technique, because the problem is the switching stick is a railroad technique. So railroad means you are dictated by the switching stick. You don't have the free hand. Arvind, nowadays, do you do the switching stick or the needle technique?
Sir, needle technique nowadays, but I started with switching technique because in initial days, making triangulation in shoulder is not so easy like knee. So 7-8 years earlier, I started with this switching stick. Now I am doing with
so
free hand.
even I confess that I have done the switching stick even for the bank cut when I started doing, because I know that I can go inside. But nowadays, if I try to do the switching stick, probably I will take much more time than the needle. So it is the question of practice how you do.
Yeah. Also with this needle technique, you may be in superior where you want to make the portal. You will be there. Maybe superior
that's why I told you, because your problem is when you come with your switching stick. Suppose your primary posterior portal is at the 50-yard mark of your posterior glenoid rim, automatically it will come horizontal from the front side. Because when we try to put your instruments or your anchors, it will be parallel to the glenoid surface, which is not the ideal. If you come from the top side, then your hold of the anchor and the angle of the anchor will be proper. Dr. Jos, any point on that?
Yes, you described it very well.
Okay. So once you are done in the intra-articular side, then you go to the upstairs. That means we have done the ground floor job. Now we are going to clean the first floor. So I always tell my juniors that you have done only the ground floor, first floor. So first floor is the Bursoscopy. Why you go to the Bursoscopy? Because you have seen the undersurface of the cup there. But if you go to the first floor, the other room, so they will now you see the upper part of the your cuff, and also you see the undersurface of the acromion. Then we can see the AC joint. You can see the lateral edge of the clavicle, the CL ligament. So many things you can see from the other side, which you cannot see from the intra-articular side. So your diagnostic arthroscopy is not complete without doing the Bursoscopy. Anything to add, Dr. Sujit?
Yes, of course. That is the first thing you have to start doing, and you shape things and make a room with a view. That is what we were trained to.
It is the classic line written in the McGinty. It is a room with a view. So it is, if you go to the top floor, then only you have a better view. So this is the you are on the first floor. So these are yes.
Sir, can I? Yeah. Sir, during regarding creating this anterior superior and anterior inferior portal, so do you suggest continuous ingress of fluid while making this anterior superior anterior inferior portal? Because why I am telling this, in the initial days we were also doing like that. So by the time you create your anterior superior portal by the triangulation, the shoulder will be so much swollen, because you are continuously ingressing this fluid to have a better view. By the time you are coming for doing the anterior inferior portal, the shoulder is so much swollen that your triangulation will fail and you will struggle. So instead of that, if we are doing both the portal with little ingress of fluid, and then we start the fluid ingress, then it will be better, I think. What is your experience?
No. I don't do both the anterior, inferior, and superior in one go. Because you see, because if you do two
when you are planning for Bankart, sir.
No, I'm telling that. I'm telling about the Bankart because I knew that you are talking of the Bankart because you are talking of the anterior superior, anterior inferior. Because if you do primarily posterior portal, then primarily what you do? You do the anterior inferior portal means anterior inferior. Primary, you do the anterior inferior portal, which is very close to the subscap tendon. Because that is that is the second portal you do. Then you come to the superior side, which is your relay portal. Understood? So so primarily you do this one. Can you see the mouse? So this is the primary portal you do from the back side for your viewing and whatever. Then you put this portal, which is close to the subscap tendon, or is very close, going in the triangle that is the rotator interval. Then you take the other portal, which is very close to the anterior angle, because you have to be divergent on the other, you have to be convergent in the joint and divergent in the outside, so that you can see and you can, all the instruments will come close and converge intra-articularly. So primary first portal is posterior one, second is this one, third is this one. Dr. Jos, anything, am I wrong anyway?
Yes, perfectly fine. You go grazing the subscap in the anterior inferior portal, then I make the anterior superior grazing the anterior edge of the
so primary is the posterior portal, then the anterior inferior, then you do the anterior superior. There is some people I have seen that they are taking the anterior superior portal anterior to the biceps. Some people are taking this anterior superior portal posterior to the biceps. Why? Because because if you are taking this 8 millimeter cannula and 6 millimeter, that means 14 millimeter through the cuff, you are making big holes. And the second point is that if you are making two portal in the rotator interval in the small triangle, then you are both the instruments are going parallel each to other. So it is not the convergence and divergent. So if you are posterior to the biceps, you will be divergent on the outside and you are converging inside the joint. So your triangulation and the relay and everything will be very easy, as you have seen Ranjit many a times during my live surgery.
Yeah, you can play on either side of the biceps.
So remember, this is a very important one. If you are diverging and converging inside the joint, your play inside the joint will be very, very easy.
Yes.
Okay. So this is the way. So I think this is the way why I came again to this picture, because I told you this is the 50-yard mark, and all your believe me, remember, those who are very juniors, I have also done mistake. So whatever mistake I have done, I am telling in this today's meeting, that we used to thought that Barca is behind. Not that. All the structure, whatever you want to see, is the anterior to this 50-yard mark. So that's why you have to draw this line. Then only you will see the Barca. It is all anterior to that line. You see, this is the subacromial Barca, which is anterior. And once you go there in proper place, and you have to switch. Why this picture is there? I told in the intraglenoid, it will move from 12 o'clock to 6 o'clock. But here, this will move from 3 to 9. Like it will be side to side movement. Then only you feel the undersurface of the bony grating feeling of the undersurface of the acromion. Then only you know that you are in the subacromial space. I tell you, subacromial scopy is 10 times difficult than the Bankart scopy or the intra-articular scopy. Am I correct, Dr. Jos?
Yes, that's right.
So I have struggled initially. I could not see anything. Only I could see inside the spider web. For many cases, only the spider web. I have blindly saved many things, but you cannot see subacromial unless you are very cautious. I remember this thing, that you have to feel the undersurface of the acromion. And sometimes I will recommend one thing for the subacromial for the beginners. It is to do with the railroad technique or the switching six technique. So if you do that, automatically you know that both your instruments, your saver and your lens, both are subacromial. Anything to add, Dr. Sandeep or Dr. Arvind?
Railroad technique is very good technique for subacromial orthoscopy. I still used to do in my 50% of the cases, particularly when the shoulder joint is very small. Because if you go a little bit low, then instrumentation in subacromial space become difficult.
Yes,
So whenever I
always
find,
difficult.
yeah, shoulder joint is small, I used to do it by railroad technique.
Okay, okay. So this is the way, these are the, I told you, this is the Bible of shoulder. This is the first book that you read. One is this Stephen J. Snyder. So this is the way he told that remember this picture and take a print in your brain. Take a print in your brain. Why this picture is so important? It's a very simple picture. You see this cannula, can you see the mouse? This cannula is coming from top to down. So that means this is going inside the joint. And now you see this cannula which is been highlighted, this is going from this angle. So the same posterior portal, if you use for the bursoscopy and for the intra-articular scopy, just you move your angulation of your trocar, you will go inside the joint. Also, you will see under surface of the acromion. So this is the picture you have to be remembered throughout your lifetime when you do the next time your shoulder. So this is the railroad technique, as I told, because in the beginners, the bursoscopy, even with the needles, it is very difficult because it all filled with so many spider webs. Very difficult to see. Sometimes it's the feel and see. Sometimes you blindly, sometimes you save up something with your experience. But the problem is that if you blindly save up, you can sometimes save up the lens. So that is the problem. So you have to be very cautious. You have to be very cautious. Don't save the lens, because otherwise the next day the hospital management will say, okay, sir, you can take leave for some time. So this is the way how your so this is the way how you see your undersurface of your acromion. Can you see that? So this is the needle coming in front. This my railroad. This switching stick is coming. This is the glistening structure. Is your CL ligament. I have saved up. Now we can see the upper surface of your rotator cuff. Okay, so this is the way it is done. For your cuff, I told you the cuff portals are completely different from your bank cut portals. From your primary portal for the cuff is also, I told you, it is different. And also for the bank cut, you do how many portals? Total 3. One is the backside, 2 in the front, antero-superior, antero-inferior. Remember, antero-inferior portal is for the anchors. Antero-superior portal is for the relay of the sutures for bank cut. Clear? And but for the rotator cuff, it is completely different, because you see, Dr. Jos, because he is too much experienced. If you follow him at the beginning, then you will be in problem. He started from this place, but now he has moved to this place. So I know that he has started from this place. But once you are experienced, because to save some 10 minutes time and also to save some fluid loss. And the third point is that if you don't want to solen the shoulder like the watermelon, because after the rotator cuff, shoulder looks like a watermelon. Okay, because if it is green outside, but it is all red inside. So that's why it is known as the watermelon shoulder. You should not go for the watermelon shoulder. So this is the way why he is doing, because by that way he's saving some time, and also he will be dead on this is known as the bird's eye view, because you are on the top side. That's why he's from the beginning, he's on the bird's eye view. Dr. Jos, anything to add on, because you are the master of this portal?
Yeah, that portal also helps us to look at the subscapularis in the front with a 30-degree scope. You can view a little bit in the front as well. So that is one advantage.
Yes, from the back side, it is with the 30-degree lens. It is very difficult to see the subscap and the lesser token, your lesser tuberosity. But if you go with the 30-degree lens from the posterolateral corner portal, it is very easy with the 30-degree lens even to see the lesser tuberosity and the subscap. But if you have a 70-degree scope, which is a bit costly because primarily your management will not give you this 70-degree scope, or it is very difficult for the beginners to buy all this scope 30 and 70. So it is better to go with the cup surgery. That's why I have given a red arrow, because this is known as the bird's eye view of your cuff. So this is the way, this is the saber is coming. This is the another cannula which is coming for this is the brown arrow is for the scorpions or the vipers. Okay, and these are the another one is this is a relay for the sutures, and so many things coming. So 4 minimal portals you need for the cuff. 3 maximum for your bank cut. Sometimes you may add 5 o'clock portal for your bank cut, but 4 or 5 portals are minimum for your cuff surgery. But don't, for the sake of doing 5 portals, I told you, cautioned you, we should not be looking at the end like a watermelon. So many other portals you can make, like Dr. Jos was mentioning, like his Wilmington portal. He is very fond of. I told you that you can primarily do the posteromedial portal, or you can do the windmill portal, which is 1 centimeter this way and go in the front. So these are the permutation and combination. This is not like 1 centimeter, 2 centimeters, no hard and fast rule. Your needle, remember the best friend of the arthroscopic surgeon for the shoulder is a spinal needle. Am I true, Arvind?
Yeah, rightly said, sir. This distance vary according to your abduction of the arm, at the same time the size of the shoulder also. So
yes, so the best friend is the spinal needle. The spinal needle will dictate me. Once I see the spinal needle, then only I create my portal. This is my theory, as simple as that. So this is known as the smiling view of your portal. Smiling theory for your cuff surgery. Why is known as the smiling theory? Because if you see the 1, 6, 3, 5, these, if you see the front side, it is looking like a smile of a face. It is looking like a smile of a face. So you start from 1, then Sujit sir will go like this. Then Sujit sir will create all these portals. And this is the far lateral portal for your biting purpose. 3 and 5 will be for your anchors. And this biting purpose, because you have to go parallel to the undersurface of the acromion. So this is 2 centimeters from the lateral margin. And this 4 is the anterior portal, which you might created by your switching stick. Okay. So whenever you are going to create any portal, please stick to the anatomical landmarks. Don't violate. Don't force the trocar in, because if you force, it will bleed. You won't be able to see. And then the one problem will happen. Even your AC is maintained at 16 or 18, you will be started sweating. So that is the main problem. And if in trouble, reassess the anatomy. This is the basic teaching for anything. Even if you do suppose a total hip surgery, if you are in problem, reassess the anatomy. So why we reassess your anatomy? I told you, one policeman in the inside the shoulder. What? That is the biceps. One policeman is still there in the first floor, which is that is the CA ligament, or the anterior corner of your acromion. So one policeman is standing in the ground floor, that is the biceps. Second policeman is the CA ligament. So creating the correct portals is the beginning of the success. So I told you repeatedly, 50% of your Bankart surgery is done if you can create a primary posterior portal in one shot. So instruments, so many instruments have already been discussed. I go very fast, otherwise it will be lengthy. Like cannula, I told you, cannula is mandatory for your cuff, for plus minus for the cuffs for the seniors like Sujit, Arvind, Ranjit and all those. And spinal needle is the best friend of your shoulder surgery. Probe is mandatory. This is the extension of your finger. I told you during the knee scopies. Switching stick, I told you during the railroad. Tissue elevators that I showed you during your Bankart also, this is needed for the cuff. And suture passing instrument, this can be antegrade or retrograde. What is mean by the antegrade and retrograde? Antegrade means in one shot, you can pass the suture. Suppose from the downside of the cuff, you can pass the suture to the top side. So that is known as the antegrade passing. But when you pass your suture from the back, top side to down and relay the suture from the other side, so that is known as the retrograde pass. So it is very simple. So it goes from the down to up, that is known as the antegrade. So you are talking as a normal bite like. But if you are coming from the top to down, relay with the prolene suture, so that is known as the retrograde. So it is no confusion, very simple. Then the suture retrieving is there. Anchors are there, knot pushers are there, suture kata. These are all very simple things. You all know saver and bar is there. Radio frequency is a must. Radio frequency is a must for your shoulderscopy. You should not start your shoulderscopy without the radio frequency. I will always tell, don't buy the Indian made whatever the electrical probe is there. It is not good. It is for the cheap, but it's not good. It only bars the tissue. It clears the tissue. Am I correct, Dr. Jos?
Yeah. Always have a good radio frequency probe.
Yes, and don't reuse, because the main problem is the reuse is that sometimes the metal in front of your radio frequency, it becomes loose and it floats inside the joint, and the post-op X-ray will sign that, and patient party will ask you what this ornament is there inside. It was not supposed to be there. So that ornament will stick you in your neck. So that is not good. So you have to be very sure that the metal is not floating inside the joint.
It comes up in the arthrocare ward.
Yes.
Is notorious.
So, this can happen, because if you reuse for 2-3 times, the whole metal chip will float inside the joint, and it is so small you cannot retrieve it. That is the problem.
It doesn't come the vapor wand because of that. It doesn't come off.
Yes.
I used to
So
use.
Well, better not to mention companies. Just
Yeah.
No, I'm not mentioning any
Sorry.
company. So these are the clear cannulas that you can use. These are the cannula. These are the cannula inserter. Even you can use these. There the dilators like this thing. So these are because why these spiral things are there? Because you are passing through the deltoid. So the cannula has to be properly set inside. It should not come out smoothly. Understood? And another one trick I tell you: don't reuse the cannula. If you reuse the cannula, please check the mouth of the cannula which is going inside, because the plastic can break. If the plastic, these are small pieces, it has happened to me, it has happened, I know that this has happened to Sujit and everybody, it is very hard to remove it. So these are the plastic insert and all these are all very common things. I am not, the Suhan cannula is also there. So many companies are there. This is the switching stick is there. And the LEPSU elevators, probably you have, this is mandatory. I told you during the banquet, small clip I have told you that this is the elevator you have to use. This is the rest. You know the rest purpose, because you have to make the bone big sort of eroded sort of, if you have to make the rough bone. So this is mandatory for your banquet surgery. So there are so many mobilizers are there, because you have to mobilize the cuff, because the problem is the cuff is that cuff will retract. Dr. Sujit, how you mobilize your cuff? What is the trick on that?
I use a pulling suture, and then with the shaver or the radiofrequency probe, I release it from the undersurface of the acromion or from the undersurface of the cuff.
Yes. Bhupesh is not telling anything. Bhupesh is saying that whatever I am missing something. I think he is too busy with the mobile. Bhupesh, anything to add? No. I will. If I see that you are not participating, I will drag you.
When master is talking, others are quiet, sir.
No. I know that, because if you are not listening, I will drag you. No, that is the thing. So this is the anchor guide, because your anchor guide has to be there. Because why the anchor guide? Because the anchor guide will protect you, because if you once you have drilled it, because small drill holes, if you want to give your anchors, it will lose the angle, the anchor will break. So the anchor guides, it has to be stable, your drill should be proper. It can be metallic anchor, it can be bio anchor, it can be suture anchors. But for the purpose of sake, believe me, nowadays it is recommended, the metal anchors are abundant in the banquet. Bhupesh, your thought on that?
I don't use metal in glenoid at all, sir. Only
Yes.
all suture anchors.
So
because now all suture anchors are less than 2 mm. So for need for real estate in the glenoid, smaller anchors without any material is truly bioabsorbable.
Yes. So this is a comment from another one master in our team, Bhupesh. So he is telling that all sutures for your banquet. So I have already been shifted to all sutures. So the day it was available in India, we have all been shifted to all sutures. Arvind, you are all sutures for the banquet?
Sir, little bit of metal anchor is still, and but mostly all suture anchor.
Sandeep?
Peak. Or
okay.
bio.
Sujit sir?
All suture, last 3 years.
So I know that you will be doing all sutures. I know that. Ranjit, I know that you are nowadays. Ranjit is using all sutures.
All suture.
Because I have demonstrated one surgery in Bhubaneswar with all sutures in his place. So
but
this
Dada,
is the
just one question.
Yes.
We have used this low profile metal suture anchor for very long time. And at the time of surgery, if your placement is good, hold is good, and we are seeing in follow-up also the anchor is remain there. So why so much of effort with this metal suture anchor? Because
yes, I understood your question. The problem is the metal anchor is that the metal is permanent.
Yeah.
Second thing is that if there is metal is proud, it is very difficult problem that we will erode on that for the beginners. And third thing is, if there is a revision surgery, if you want to do one revision banquet, then you cannot retrieve that metal anchor. But if you use the suture anchor or your bio anchors, then even you can drill through that, you can make a new thing. So these are the revision surgery is difficult with metallic anchors, but the hold with the metallic anchor is not a problem. Am I correct, Dr. Jos?
Yes, I'd like to add something. Recently I revised a banquet surgery where 3 metal anchors were used in a big hospital, but then all the 3 anchors were proud. The eyelets were proud, and it was hitching on the shoulder, and patient is having this tingling and shooting pain when it happened. happens. And
Recently, like, so this is the problem.
So basically, it's the problem with the technique.
Yes, exactly. So,
two problems. One is the technique. Second is the resurgeon, redo.
And if a metal anchor is to be used, use one of the good companies. I don't say Indian or foreign, but then
no Indian at all.
They can stop midway.
Yeah, definitely.
Midway, you are stuck.
Indian at all.
Yeah. All suture anchor is all foolproof.
Yes.
So even for,
like Dr. Arvind said, we all started doing bank cut with metal anchor. So nothing against metal anchor, but the reason why I shifted is precisely the second reason that Samanta sir said. It takes away a big part of the bone from the glenoid.
Yeah.
And we cannot afford to take away so much of glenoid with an anchor, because in revision it is going to be a headache, because glenoid real estate is very important. We cannot take away so much of bone. And
so the
2.8 or 3 mm is quite a big. With 1.5 or 1.7 all suture anchors, you almost don't lose bone at all. Hence, everybody have moved to smaller anchors, which are all suture anchors.
Yeah, rightly said, Dr. Bhupesh. The metal anchor problem with in case of revision is there.
Oh, that's why I told you that the main problem with the metal anchor is not because of the hold. It is of the two things. One is the proud anchors and second is the revision. It is not because of the hold. So these are the suture lassos and so many things are there. I told you what is the meaning of antegrade pass, what is the retrograde pass. When you use the lasso, it is retrograde obviously, because you are passing either the metallic wire or the prolene suture just to retrieve your fiber wire. So I think when you go ahead with your cup surgery, when you master your bank cut, then only you go at your cup surgery. Otherwise, it is half sort of how we have done, like 25% done with the scopy, rest 70% with the maxi incision. Then I have done 50% of the scopy with the mini incision. Nowadays, we are doing with the all arthroscopic, as Bhupesh is doing, like all arthroscopy, like Sujit is doing, Arvind is doing, and all are doing. Even we can do the all arthroscopic cuff repair now. So this is the way how you pass your sutures, how you pass your anchors. This is the another one technique how you pass your this is the grab your sutures with your this sort of bike which is go inside. Antegrade pass you can do the retrograde pass. Now we can have even with the antegrade pass you can pass the suture and catch the suture. It was not there when we started. It was known as the second generation antegrade pass. Sujit, you have used those second generation antegrade pass?
No, I don't. I use the direct suture passes, the true pass or
yes, sir. No. The Acupass did just come recently. I am talking about the antegrade pass, which is first generation, second generation. When the catching was not there, the catching has come hardly for 5-6 years.
Yeah. Only one company has. I have not got hold of this yet.
Okay, so this is the way how you can use the Bartbeaks or the penetrators. Even you can do for your cup surgery, because some bends are there, up bend are there, and also some side bends are there. Right and left value is there. How you know it is right and left? Because if you hold it properly grab, and if the angle is going towards the right, it is a right-sided pass. If it is going to the left side, it is a right side. Is a red and blue mark is there. Red is for the right, blue is for the left. It is easy to remember. I think, Jos, I'm correct?
Yes, perfect.
Okay. So these are the Kruse hooks. This is a very, very friendly instrument. This is for your retrieving the sutures inside. It is both used for mainly for the bank cut. Even you can use for your cup surgery. So suture retriever, this is known as the magic grasper or the suture retriever. These are small ones. The bigger ones are for the bigger one is the crocodile, or the kingfisher one is for the grasping of your rotator cuff. This is the bigger one. That is the smaller one is known as the suture grasper, suture retriever, or the magic grasper is known for a particular company. I'm not naming the company. So this is the first generation, the second generation. The first generation was there when you could pass the suture only, but you have to catch the suture from the other portal. This is the first and second generation. But now that is Sujit is doing, I think Sujit is using this one. When it goes there and also it will catch there. So in one go, you don't have to go to the other portal to retrieve the suture, again come back to the same portal for the suture to come again on the same portal. So one step is reduced. Okay. So Vipers were there. Nowadays, when we started because the Viper was a very, very common instrument in US. And also one of my mentors, he was using this Viper for his all surgeries, because Viper was the only instrument when first generation, second generation, your antegrade pass was there. Viper was the only instrument which was catching the suture. So it was there in the market. So knot pusher, I will tell thrice, don't get bored. It has to be a foreign one. It has to be a foreign one, and it's to be a not foreign one. It's a smooth one. Smooth one means this part of the knot pusher is the important part. It should not abrade your sutures, because if it is not smooth, if it is abrading, your suture will break, and you will again feel that I am not doing a great job. Again, even it will be very problem, because passing the suture, whatever you have taken to your pain, then during the knot, if it breaks, then it is a problem for the surgeon. 6-finger knot pusher, I have seen one of my mentor, he was using, and he is still using, and he just retired in the Jan. So I do have with my, because when I was trained with him, it was a 6-finger knot pusher. Sujit, have you seen this one, 6-finger knot pusher?
No, I haven't.
This is probably used, and this was invented by Barkhardt, probably. I think
I have seen that.
Yes, because when I went there, so it was available. I used for some cases once I seen him, but I'm not using that, because I use that. Ranjit, you know that whatever the knot I'm using for the Bankart, same is for my cuff, because I am a simple person. One knot I learned, I don't forget that knot. Suture cutter has to be a good one, like your knot pushers, because it will not. You should not chew the suture. Okay, it is meant for the cutting purpose. It is not for the chewing purpose. So it should be a good one. So arthroscopic pump, who is using the arthroscopic pump? Yes or no?
Yes.
Yes, sir.
Yes. For
So
cuff.
I think Bhupesh is not using 100%.
Sir, I actually use the pump for all my cuff surgery, sir. Bankart
Only for you use the cuff?
Only for cuff.
Surgeries I use.
Only for the cuff. Okay. So this pump I do have in my OT. I started doing, but I thought this at least once I get some experience with the cuff surgery, I'm not at present using the cuff. But once you start ahead with your cuff surgery, it's better to use the pump, so that you can see properly. Otherwise, your problem in seeing, the problem with the cuff is that once you start some oozing and bleeding, you go on increasing the pressure. Then ultimately it becomes again the watermelon shoulder. So that is not the intention. So your main aim should be at the end of the surgery, both the shoulders should be looking more or like same. The right shoulder should be looking like the left shoulder. It should not be looking like the shoulder and hip. Sometimes after this thing, it becomes one shoulder and one hip for the patient. It should be both looking like shoulders.
Sir, one point about the pump that I learned after a lot of mistakes is the pump usually is the last instrument we buy. So it should never go into the last trolley of your tray. It should be higher than the patient or same level of the heart of the patient.
Yes.
Have a separate stand or a separate trolley, but in the arthroscopy tower, it should not be in the last one, because usually it is the last one we buy, because it has to pump that much more to get the same pressure.
Yes.
Never go more than 35. If you are more than 35, something is wrong.
Yes, because I have seen sometimes during the passing of the sutures, many big surgeons is going like 60. So this is a problem, but you can go to 60, but if 45, 60 or whatever, but it should be a very small time sort of thing. Once I asked one of my master, because I was for a long time with that master, I told, sir, how many steps there are in a cuff surgery? He told me there are 360 steps in cuff surgery. If you took 1 minute for 360 steps, now you calculate the minutes and now we divide by 60, then you understand why it is one shoulder and one hip. It is 6 hours. So you have to curtail every step for your cuff surgery. Otherwise, you cannot come as a good surgeon.
One more point in this pump, along with the pressure, the flow rate is also very important. That should also be monitored.
Another one trick I'm going to this thing. One company, I'm not giving the company name. They are giving one special IV channel. Along with that, these 2 hand sort of pumps are given. So the fluid will accumulate there. Suppose like 50 mils, you will pump 2-3 times. Again, that 50 mils will go inside in a jet. and that will act like a temporary sort of pump. That is very safe. You can search in the market, you can talk to the seniors, you can get that. It is available in India. That is very safe. And thing is that is not only safe, it will save you 10,000 to 11,000 of you, because this 10,000, 11,000 is the cost of the channel for your all these arthroscopic pumps. So this is another one important point which you have to use during your cup surgery, and also some people do use for your Bankert surgery or the shoulder surgery. So this is your radio frequency probe, radio frequency, the pedals. This the yellow one, as you remember, like your electrocautery, this is your diathermy. The yellow one is for your cutting, and blue one is for your coagulation. Same is true for your radio frequency. So because why radio frequency, I told you it has to be a good one, only because if you this thing I was referring to, because the metal, can you see the metal? If you use this metallic instrument many a times, then this metal is not very solid. It is not been solidly fixed over there. Sometimes the metal can come loose. So after 2-3 cases, please don't use it for your many purpose. If you see that it is like it should not be reused. So I think we have taken a length of discussion in the basic things like your how the position should be, how should be you have to be critical in lateral, you're taking care of all the safety precautions of the patient, both in lateral and beach chair. What are the advantages and disadvantages of your beach chair and lateral? Then how there should be, you should be very easy for your portals. And also I have tried my level best to explain some of the basic instruments for the Bankert and also for the cuff. If anything is left, I have forgotten, then my colleagues or my umpires like Sujit, Bhupesh, Sandeep, Ranjit and Arvind, they will tell me and guide. Thank you very much. And this is the picture. Every time I go for the shoulder meetings, I tell them that this is the question of your precision and the speed, because shoulder surgery is your precision is 100%, and also you have to acquire some speed. And you see, somebody is seeing there, he is sitting there, whether your precision and speed is fighting, because if you both this precision and speed is not there, again the problem is the shoulder and hip. Both at the end of the surgery, it should be looking like the shoulder, then only your surgery is successful. It should not be shoulder and hip. Thank you.
That was wonderful, Dr. Samanta.
Samanta sir, it was a fantastic meeting. You covered all the basics of shoulder arthroscopy. I think a lot of beginners would have really enjoyed. It was a very interactive session, and with your expertise, you made everything look very simple, and the fear of shoulder arthroscopy would have gone out of people who have listened to your lecture. Thank you, Samanta sir.
Sujit, anything to add on? I will come one by one.
Yeah, you went through all the points very, very clearly. And one thing I'd like to tell to the people who are going to start is never try to fight the blood pressure or bleeding with the pump pressure. If you're having a pump, never go up to 50, 60 and all. Never think about it. 35. That is shown in the picture. Never go cross 35. If you have to cross 35.
That's why I have given that picture. Yeah.
Yeah. Tell the anesthesiologist, bring the BP down, wait for some time, and then go ahead. In my initial days, I had these watermelon shoulders. I remember a patient who had this fluid leaking out all the way down to the chest, and the one breast got engorged. Not the shoulder, the breast got engorged.
Even it is written in the literature that if you keep too much fluid inside the joint, even sometimes the patient can have some breathing problem after the anesthesia is over, because they are told that because the trachea can sometimes move the other way. Even this is written in the literature, and they even given Lasix for just decompression. They have observed, they are again re-intubated and kept for some time so that the patient, this swelling is reduced, and again he is breathing properly. So your fluid management, remember what I'm telling, fluid management is extremely critical during your cuff surgery, because Bankert surgery is intra-articular, but your cuff surgery, it is the endoscopy. It is not arthroscopy. So your Bankert surgery is arthroscopy. Cuff surgery is an endoscopy. So
sir, I had a similar problem, sir. So my friend's classmate's mother, I was doing the cuff surgery. So we should be careful in small ladies with a short neck. and we should be very careful regarding your fluid management. Even if the fluid management was good, still it was a massive cuff tear, so it took around 2.5 to 3 hours. And by the end of the surgery, when we unwrapped everything, and then the anesthetist showed me that there was the crepitation over the neck, and he suggested me that we will not extubate the patient, let the patient be in ICU for observation. We keep the tube for 12 hours, and then we can extubate. It will be better. And we did exactly, but their attendants, when the lady was out of the OT and when he was shifted to ICU, they were very apprehensive. With a shoulder arthroscopy surgery, the patient is shifted to ICU and the neck is swollen like that. So these are the things we should be very careful when we are dealing with a short-statured lady with a small neck
Ranjit,
and a chubby neck.
Yes, Ranjit, Ranjit, that's why I was really been joking sort of thing, but I was talking in a lighter mode. But all this, whatever I have told in the lighter mode, this you have to take it seriously, because this has all been learned in a very hard way for us. Why is the meeting basic arthroscopy or the basic D? Because we want our juniors should not make the mistakes what we have done. Because in our time, the learning the shoulder arthroscopy was very, very difficult because there was no mentors around. We have to move from door to door to learn one trick. But we are here to teach you everything. Whatever we have learned for last 20, 30 years, we'll give you everything. That's why we request you to come to join to IAS and come to our meetings, and we'll give you everything, whatever we have learned in a very hard way.
Thank you, sir.
Excellent one. Very nice presentation, Swarnendu, as usual.
Excellent presentation, sir. Nicely described all the aspects. Thank you, sir.
Sir, I have a question.
Yes, Prashant.
Hello, sir.
Anything to add on? Rajiv is the ultimate.
Sir, Prashant has
a question, I think. Yeah.
Yes.
Sir, we use cannula for anterosuperior and anteroinferior portal. Should we use that in standard posterior portal too?
I think I could not understand what, because my net is
cannula.
I think his net is not proper. His voice is cracking.
Prashant, yes.
Sir, we use cannulas in anterior, superior, and anteroinferior portals. Should we use that in posterior standard portal also, or should we proceed with only incision?
No. The posterior portal is, I told you, it is a viewing portal. Because it is the posterior part, you are close to the acromion, you are not going to change. But if you want to change the posterior, sometimes some people are doing the Bankart with the anterior superior portal coming to as the viewing portal, and the posterior portal as the relay portal. Anterior inferior portal is for the anchor portal. If you come to the anterior superior portal for your viewing, then your posterior portal became your relay portal. So if you use the posterior portal as a relay portal, then you have to use the cannula, because otherwise you lose the sutures in your deltoid. So if you do the posterior portal for your primary viewing portal, it is out of question. 2 cannulae in the front. But if you see the anterior viewing portal, anterior superior portal, then the posterior cannula, posterior portal becomes your relay portal. So then you have to use the cannula. So I think my answer is, I have given the proper answer for your question.
Yes, sir.
But there is no harm in using cannulas in all 3 portal as well.
Yes.
No problem. No. You can use the posterior portal even, but the problem is that you will lose too much of fluid. Why? Because you don't want to create a 8 millimeter hole on the backside, because you will lose too much of fluid, because you want some fluid to stay inside the joint, so your surgery becomes smooth. And because otherwise, the problem, this is the theory given by Burkhardt. This is known as the turbulence theory. The turbulence theory, meaning of turbulence theory is that if the fluid goes inside very fast and comes out very fast, with the turbulence theory, there will be bleeding. So that's why your fluid management, both in the Bankart and the cup, the turbulence should not be there. Why? How you manage your turbulence theory in Bankart? You use minimum cannulae, the 2 in the front. And how you reduce your turbulence theory in cuff? I will give you the trick. You tell your assistant, the portals that I am not using, your fingers should be on that portal. Or else, another one way you can do that, a weight gauge should be on that portal. So this reduce the turbulence theory, which is being proposed by another one boss, which was my boss, Steve Burkhardt.
Exactly, sir. He explained the things like a curtain in your hotel, and when you open your tape suddenly, the curtain will come towards the tape because of the turbulence of the fluid you are opening.
No, I have told you, because he was my boss. I told you that this is the theory given by boss, the turbulence theory.
Yes.
So I made it simple.
Yes.
Whatever portal you are not using, it should be blocked. So one line you remember, forget about the other things. It will be easy.
Yes.
Because there are so many things to be kept in the brain. Na?
Yeah, Prashant is telling about, I think sometimes you need to put cannula when you are repairing the posterior labrum also. So in those scenarios, you can put cannula in this posterior portal. Otherwise, most of the time, usually don't need to put cannula in the posterior portal.
What size cannula you use, sir? What size cannula?
I told you during the description that when you give your anchor portal, it has to be bigger one, because your anchor sleeve will come around. So this is 8 millimeter cannula for your anterior inferior portal.
Some network issue is there.
Yes.
Portal, which is a thinner one, that will be 7 millimeter portal or 6.5 millimeter portal. Why? Because you are going through the cuff. If you go a big, understood, if you are going beyond your biceps, but if you are coming close even with the...
Yes, sir. You are back.
You're back, sir. You're back.
Yes.
So I told you that the anchor portal will be having the bigger cannula. Relay portal will be having the smaller cannula. So 8 millimeter portal for the anchor portal, and the relay portal with the smaller cannula, which is 6.5 or 7. I think, Sujit, we have covered most of the things.
Yes, of course. Yeah, and for the you could tell about rotator cuff as well. The cannulas for rotator cuff, if you use any.
Yes, cannula for the rotator cuff is that the bigger. What should be the biggest cannula? Biggest cannula again for which will be taking your scorpions. Scorpions will be the bigger cannula. The smaller cannula will be for the suture retrieval purpose. Even people are not using only one cannula for your suture passing the antegrade pass. Others are very free, because why? Because you are close to the acromion. Here the deltoid is very thin. So you are not, because in the Bankart, you are going very down. That's why you have too much of deltoid is there. You have to use the cannula. But once you are close to the acromion, it is just, once you prick, you will go inside in the subacromial thread. So it is not mandatory to use the cannula in the front and back. But this is mandatory to use the cannula where from the far lateral portal, that is 2 centimeter beyond the lateral margin of your acromion, because this is the thick part of the middle deltoid. So there it's mandatory, because otherwise every time you pass, you will catch through the deltoid muscle and your sutures will be strangled in the fibers of the deltoid. This is very, very problem. Once you tie the knot and you see both the knots are not stitching, then again you will start sweating. Sweating is not good for surgery.
And always by the shorter cannulas. The 70 mm ones are always better, because you'll have more space for the instruments to move and work.
So that is what Sujit is mentioning. That is known as the passport cannula.
Yes.
So the bigger cannulas are bigger one. Bigger one means it is a bigger length. So your hands will be tired, because you have to work like this. But if you use the passport cannula, then the passport cannula it is like it goes inside and it is like a valve. So again, one valve is there. So once you drag that valve, it is all two purpose. What is it? It is been stays there, and also it will just take off your deltoid. So your seeing and everything will be very easy with your passport. I think Sujit is mentioning that thing.
Yeah, I used to use the passport earlier. Now I use the regular small cannula, which is 70 mm.
The problem is that once you are expert, you can palpate the liver from the right and left.
Thank you very much.
I think this was this. I tried to make it simple, because even with
it
some
was very comprehensive and simple.
So I have mixed with some jokes and funs, only because this is an absolutely basic thing. Whatever the hard way I have learned my shoulder arthroscopy, I tried to give you everything. I have nothing hidden in my heart today. Whatever I have learned in the hard way, I have told you everything.
But we have one question.
Thing is that this is a nice podium that I have got Sujit with me. Bhupesh is very, very experienced surgeon. He is doing great job. Ranjit is there. Sandeep is there. I'm really lucky I'm around with these guys. And the third umpire, Rajiv, is also there. He was silent, but he was there only to say whether I am in the right track or wrong.
No. You are always on right track. Yeah.
Sir, we have one question.
No, I'm joking. I'm just joking. Rajiv, don't take it otherwise. Don't. It is a friendly meeting.
Yeah.
Yeah. Sir, we have one question in chat box from Dr. Devinder Lal. He wants to know, like, anyone has experience with the warm saline?
Warm saline is not warm saline. You can because the problem is that suppose in the Bankart this saline what we use, because problem I told you during the hypothermia is a problem, because in the cuff, because the placenta will be probably floating with the water if your draping is not water and airtight. So you have to be cautious about the hypothermia, airtight and watertight draping should be there. If you use the cold saline, the hypothermia will be more. So your anesthesia will be, the anesthesia will be annoyed, because in hypothermia, what is the problem? Your reversal becomes problem. So that is the headache. So you have to take care. It is not the warm saline, it's a room temperature sort of thing.
Sometimes some people mix adrenaline also. So what is your suggestion on that?
Yes. Some people are using the adrenaline for the cuff surgery, but problem is that, Rajiv, that if you use the adrenaline in every bottle, you don't count how many adrenaline you are giving, and the anesthesia again, they are not very happy. So I think the hypotensive anesthesia along with the brachial block, where they can maintain the hypotension for the cuff, because you don't need hypotension for the Bankart. Because I told you this is the intra-articular job. Your fluid is not leaking because it is a compartment there. But in the cuff, every time you do something, it is leaking in the soft tissue, because this is the endoscopy. This is not arthroscopy.
And in addition, adrenaline causes some hypertension. Although it causes vasoconstriction, it can theoretically at least cause some hypertension.
No, the adrenaline is problematic. I have not used, and I'm not support using the adrenaline for my purpose. But problem is that once I told you there are 360 steps in rotator cuff surgery. So every step you have to take down some seconds for this. Otherwise, it will be 6 hours for a cuff.
Using of manual pump and automatic pump, what is your suggestion? To decrease swelling, whether it is good to use a manual pump?
I have already told that what is the machine pump and what is the manual pump. Manual pump you never use because if you don't have any control. But some people don't. That is the BP thing goes inside the fluid, and it is two purpose. You don't have any control how much pressure you are putting in, and also you don't know what is the sterility. So that is the problem. So two problems are there. So it is better. I told you that one India it is available that some of my friends they are using that the channel what are using. There is a one small in between where the 50 mils of saline or 100 mils of saline will be stored inside. If you give 3-4 pumps, it will be used like a transient pump. So that is available. I can in the open podium. I cannot tell the company name, but you can. It is available in the market.
It is better. Yeah.
So I think Sandeep, if there is no question in the YouTube or our channel, we can summarize with two of our. I think Arvind has lost his connection.
Yeah, I think Dr. Sujit is there. He can.
No, I think Dr. Sujit is the senior most, so he will conclude.
Yeah.
And from the IAS side, Bhupesh and Ranjit, they can close the closing remark after Sandeep and Rajiv. Okay. Sujit, anything to add on, or how it went through?
I think we went through all the simple small tips to start shoulder arthroscopy. Any knee surgeon who wants to go to shoulders would have had most of the small fears allayed, I think. But then it's always important to have that practical touch. Theoretical swimming is not possible. You always have to go through the hard ways, like watermelon shoulders and watermelon hips. It is all important. You have to go through all that difficult steps before you go to do good surgeries. And I'm thankful for IAS, Dr. Sandeep, to inviting me to be a panelist here. It was a wonderful discussion we had. Dr. Karthik, Dr. Panigrahi, Dr. Rajiv. Thank you, Dr. Samanta, for your wonderful talk. It was very informative.
Thank you, Dr. Sujit, for coming, because this is the podium. This is a friendly podium. Every time You come here, you will enjoy 100%. And there is a small request also to you, tell all your juniors to become member of the IAS so that we can make a bigger family.
So the next webinar from IAS, our webinar number 79, is by none other than Professor Andreas Imhoff, who is a professor in TUM, Technical University Munich. He's a fantastic, versatile surgeon. He does all joints, and I was personally with him. I learned my 5 o'clock portal in the shoulder when I was with him in Germany. He will be talking on AC joint injury and where we are today. So it is a fantastic webinar, and everyone can join this on Saturday at 7 o'clock on 5th September 2020. And thank you, Dr. Sujit Jos. It was fantastic having you here. Your inputs were very valuable. And thanks to Dr. Arvind. I think because of a few net issues, Dr. Arvind Gupta could not continue with us now. Thank you, IAS team, as usual, and our secretary. Fantastic job, sir. We really enjoyed learning with you again.